Well, good evening. Thank you for joining us tonight. I am Ann Keel-Dux, moderator of the In the Know Town Halls, candid conversations on health topics that matter to all of us. Thank you for joining us, of course, as we continue our In the Know series called The Science of Aging. And thank you to the Coral Gables Community Foundation for their partnership on the series. Tonight's topic is top of mind for most of us. After all, aging is inevitable, and the battle of the bulge is everlasting. As we age, managing weight becomes a high-stake balancing act, complicated by conditions like diabetes and hypothyroidism that throw our metabolism into disarray. And with metabolism slowing down and hormones fluctuating, the challenge isn't about shedding pounds necessarily. The challenge is really more so about navigating the body's changing rules. Tonight, with the help of our elite experts that are on the stage with me right now, with UHealth and the Miller School of Medicine, we'll dive into the key treatment, research, and lifestyle interventions of weight management. Before we open the floor to the Q&A portion of this event, I would like to invite Dr. Roy Weiss to give his opening remarks. Dr. Weiss?
Good evening, everybody. Thank you so much for coming, and I want to thank the Coral Gables Community Foundation as well for helping sponsor today's event. I'm so pleased to be here because we're truly at a precipice in terms of the golden age of weight management. Never before in the history of medicine have we been at a place where we are now, where we have not only medications that are available, and you'll hear about those, but also in terms of lifestyle management and changes. The new data being published every day, you might have heard about intermittent fasting. There are also other opportunities for the types of diets that you have. I know we are very attuned to South Beach diet, being where we're located, but there's other diets, natural food, uncooked food, all sorts of things. And all of these together make up part of our armamentarium that we have, in addition to surgery, in order to master and to take care of weight management. Now, I have with me my colleagues from the University of Miami this evening who are going to answer your questions from their perspectives. We have over on the far right, we have Dr. Ernesto Bernal Mizrahi, who's professor of medicine. He is one of the leading researchers in diabetes in the country, and he's chief of the Division of Diabetes Endocrinology and Metabolism. Next to him is Dr. Nestor de la Cruz Munoz, who is professor of surgery and one of the leading bariatric surgeons, does over thousands of bariatric surgeries, and is an expert in the metabolic effects that surgery has. To my right is Tracy Crane. Dr. Crane is also a professor of medicine and is intimately involved in wellness programs and cancer survivorship at the Sylvester Cancer Center. And then to my left is Dr. Gianluca Iacobellis, who is a world-famous researcher in terms of metabolic disease and how it affects the heart. So these are a broad perspective of specialists in the field of medicine and surgery that all deal with weight management. And I can tell you, if you want to talk about a disruptor, we talk about major environmental disruptors, what's happening in the world of obesity is truly a disruptor, not just for medicine, but for finance, when you think about the effect it has on the airline industry, the fast food industry, the clothing industry. I won't get into my details now, but I can tell you many stories about how weight loss can affect all those sectors. So at this point, Ms. Dux, I'm going to turn it over to you, and we can begin.
Thank you, Dr. Weiss. And you are so humble, we should introduce him as well. Dr. Weiss is the chair of the Department of Medicine at the Miller School. He's also the Kathleen and Stanley Glazier Distinguished Chair in Medicine and the Rabbi Morris S. Forms Endowed Chair in Medicine and Endocrinology. So thank you, Dr. Weiss, for being with us this evening. So when we talk about this Q&A, I really think it's important, as we already discussed and mentioned, there are so many fantastic experts here on stage, each with a different specialty and focus area. So I think it'd be fantastic to start off this conversation really understanding what is trending in your field. And I think we could probably take this maybe left to right and hear from each one of you.
Okay. Well, so, as an endocrinologist, I think similar to what Dr. Weiss mentioned, we are now at a very exciting time because now we have a lot of resources and medications to be able to use for obesity. At least in my case, obesity and diabetes go, hand by hand. And in my work in research, I'm more focused on understanding some of the mechanisms that cause diabetes and how we can, treat and design novel therapies for diabetes.
As a surgeon, there are three things that excite me really quickly right now in our field. GLP-1 drugs, which is kind of interesting, but we're using that in addition to our surgeries on our patients, and it's helping supplement what we can do with our surgeries, and it's been great for us. Two is less and less invasive procedures are coming out, and we're doing more minimally invasive things endoscopically these days than we haven't done in the past, and that's a huge growth area for us. I think we have 4 studies coming up in the next year where we're doing endoscopic procedures, not even surgical procedures. And the third one is something really interesting that is kind of be coming out in the next year is magnets. If you've never heard of it, probably none of you have, but magnets in surgery are going to take off, and we're going to start using it for putting bowel together, and it's going to allow us to do some surgeries and some anastomoses that are difficult to do right now with the standard techniques. So things keep evolving, even in something as stagnant as surgery.
Great. So thank you all for coming tonight. So my area of expertise is in lifestyle behaviors, so things like diet and exercise, things that are modifiable. We know that 40% of cancers are related to these modifiable factors, one of which is obesity. And so for me, one of the really fascinating times in this area is with these GLP-1, these agents that we now have. For me, for the past 2 decades, having somebody change their behaviors, it's daunting, right? And these medications are allowing us to really start to understand how we can take some of the food noise away, which is part of the challenge with losing weight and changing your diet, and really be able to focus on making healthy long-term lifestyle changes. And so this intersection between lifestyle modification and how it complements all of these different techniques is a very exciting time right now.
What's most exciting for me as a clinician taking care of patients is all the things that we don't know. We don't know all the long-term side effects, and we need to study those, and we need to understand what the effects are being on it for the long term. And also what's exciting for me is what's down the road in terms of new drugs. And in particular, one of the biggest epidemics that we have in the world today is childhood obesity. What are we going to be doing about our children, and are they candidates for many of these new interventions that we're doing? These are the things that I, as a clinician, am most concerned about.
Right. So what I think is exciting, in addition to what was beautifully stated by my friends and colleagues, is the fact that there is much more behind the weight loss. So what I do as a clinician, as a clinical researcher as well, is to look at the beneficial effects of these medications that go well behind the weight loss. And also looking at what we call precision medicine, so the ability that we have to customize the treatment, best treatment for patients based on some characteristics that can be extremely helpful. And now we have imaging techniques, we have biomarkers that actually one of them that I invented to develop, so that we can definitely, again, customize the treatment to specifically target the organ that we want. So there is much more behind the weight loss treatment.
Thank you. Well, just from hearing these initial comments, I have a long list of questions, maybe because I'm a former journalist, but I know you all have yours as well. Please feel free to step up to the mic. It's in the middle of the room whenever you feel comfortable, and we will be taking your questions. I also have some of your questions that were sent ahead of time, so we have plenty, and I'm sure we'll cover a lot of the important topics. Also, keep in mind this event is recorded, so if you missed something, you certainly can go back and watch it on the YouTube channel. So this first question is for Dr. De La Cruz Munoz. What makes UM's bariatric surgery program special as compared to other centers?
Wow, I think a big part of it is our experience. We've done, as Dr. Weiss said, over 8,000 operations over the last 15 years. We have won awards for our outcomes. Each year that we were eligible from health grades and different companies. So we're showing that we're getting better outcomes that they expect. And we see that some of the sickest patients in South Florida for that. So that has been a big differentiator. In addition, it's our offerings. Right now, we offer everything available for patients for weight loss. And in terms of the different surgical options, non-surgical options, endoscopic options, as I said, research options that you can't find in other places. So there's something that we can get for people that need help. There's almost always something that we can find to try to help them.
Thank you. Appreciate that. So I think top of mind for a lot of people, at least we're getting hit with a lot of the commercials, the GLP-1 medications. What can we expect them to do? What can we expect from them? Dr. Bernal, can you start us off, please, sir?
So GLP-1 is only one, and these are hormones produced in the intestine. And what the pharma company have done are trying to design medications that work similar to GLP-1. But in addition to GLP-1, there are others that we're going to probably speak later on. And what GLP-1 does is to increase insulin secretion from the pancreas, and it does also decrease a hormone that raises the blood sugar, like glucagon. It will also decrease the gastric emptying and decrease appetite. So all these are effects of these medications, including GLP-1. There are also some side effects, and most of them are gastrointestinal, like nausea, vomiting, and constipation and diarrhea. So this is kind of the summary of what GLP-1 are. But this is, again, exploiting some of the endogenous mechanisms that the body uses to regulate glucose homeostasis.
Thank you. And Dr. Crane, it makes me think about what the differences might be between some of these medications and some other more traditional, or at least some of the weight loss methods that we've used in the past. Can you talk through that for us?
So I think the biggest difference is there's no denying the clinical trials that with these medications you see basically double the amount of weight loss that you see with traditional lifestyle modifications. I think the complement of them working together because of the longer term side effects and risks is where really I think we're going to find the sweet spot, so to speak, in terms of making sure that we are keeping the weight off. So in both cases, no matter if you use more traditional energy restriction and exercise or these medications, there is the weight gain does come back when you stop either method. And so understanding how we change these behaviors long term, I think is at the crux of this. But you know, there's no denying you do see double the weight loss with the medications, but lifestyle modification is really important for overall body composition and just your long-term overall health.
Yeah, healthy habits. We all try very hard to keep up. And Dr. Weiss, when we talk about if we have made that decision to start these medications, is there a way to stop? Is there any directions as to when that should happen or how those decisions are made?
So, yeah, this is an unknown area, and anybody who tells you they know what they're doing is full of bologna sandwiches, because nobody knows. There's no hard data to tell anybody when you can stop the medicine. So we use generally good principles of medical practice, which means that you use the lowest dose for the shortest period of time that gives you positive results. And so generally speaking, that's the rule of thumb that we play. I'm sure all of you have heard about the fact, oh, you stop the medicine, you gain the weight back again. I would just like to just give you one perspective as being in medical practice for 40 years, probably longer than most of them on this panel. But I can tell you, when I would have, as an endocrinologist, patients would come and see me, says, Dr. Weiss, I eat nothing all day, I exercise like you can't believe, and I can't lose a pound. And I was so skeptical. I said, really? Just carrot sticks and celery? Absolutely. And you tell them to keep a diet log. And they lie on their diet, not intentionally, but they forgot the bag of Fritos or they forgot the piece of cake that they ate before they went to bed. So what happens is that they, all of a sudden, now I begin to think a little bit differently. There is a black box. Food goes in, energy gets expended, and if you get more food in than energy expends, you gain weight. But it's not so simple. I can tell you patients who are ravenous, they are so hungry that they don't know, they eat like a bear, as my wife would tell me, in certain ways. And so what these things have done is have sort of curbed the appetite that gives you the edge to deal with Dr. Crane, gives you the edge to think about surgery, gives you the edge to think about other things and how it'll affect your heart and all these other things. So I know that, Ms. Dukes, I didn't answer exactly your question, but I had to tell that story because the answer really is we don't know, but you do it for the least amount of time at the lowest dose that gives you effect.
Good answer. I'd like to open it up to the panel if anyone has any thoughts on this as well. Dr. Jacobellis?
So I think that, of course, these medications, they have a strong effect on the gastrointestinal motility, on the appetite, and satiety, no question about that. However, my studies and others have shown that there is a direct and specific effect on the adipose tissue. So the fat cells, so the small cells, we have particularly those around or inside our key organs, the heart, the liver, the kidneys, are really uptaking these medications and they are changing their own metabolism. So these cells are really changing dramatically and they are turning to become from being something detrimental for the organs, becoming actually a friend for the organs. So we found out, for example, that if you target the fat tissue of the heart, that fat tissue, instead of affecting the heart, with the help of the GLP-1 analogs, it becomes a friend of the heart. It will help the heart to function better. So in terms of, we don't have a longitudinal data yet. I do agree with Dr. Weiss, of course. However, what I do in my clinical practice and based on these recent discoveries of these specific effect on the adipose tissue cells is that you should keep these medications as long as possible to keep active the biological effect of this medication on the adipose tissue, which is much more important than the effect on the satiety, appetite, and other psychological component of the medications.
Really interesting. The direct impact on the heart is something that at least was new for me. I thought that perhaps it was secondary, but very interesting research. And we have our first question of the evening.
Hello. I'd like to ask a question. I think this is probably for Dr. Crane. I'd like to know a little bit more about intermittent fasting, and is it different for women, different for men, different for women in menopause, age-related? So I'd love to know a little bit more about that.
Good question. So intermittent fasting or time-restricted feeding has gotten a lot of attention in the past, I'd say 5 years or so. It's really based along circadian rhythm science and aligning circadian rhythms and getting your body. So we actually have a trial right now at UM in metastatic breast cancer patients who are looking at time-restricted eating and fatigue as one of the outcomes. To answer your question in relationship to weight loss, I think time-restricted eating is a safe, it is an effective way. It's easy for a lot of people to do. I recommend that people try stopping eating by 8 o'clock at night and then fast for 14 hours. 12 to 14 hours, and then pick up your eating again the next day. If you do it overnight, you sleep a large percentage of that. Most people report better sleep. They report that they actually have better glucose control. There's a lot that goes into it. I think it's been one of my most successful interventions in terms of adherence and long-term uptake. Once people start this behavior, it's actually fairly easy to keep up. So I am a big fan of it. In terms of men versus women, I don't see differential effects in terms of men being less successful or more successful with it versus men. I think in my experience, it's been easier for men to do than some of the other dietary patterns that we've asked people to follow. So I would say it's been a little bit more successful compared to just like changing fruits and vegetables and eating healthier.
Thank you, Dr. Crane. And just as a reminder, feel free to ask your questions. If you'd like to just simply raise your hand, we will send a mic your way as well. We'll make it easy for you. And I'd love to talk about BMI. I feel like it's come under fire a bit more recently, at least from some of the articles that I've been reading. And Dr. Bernal, can you talk to us about body fat percentage? Is it more critical than your BMI regarding medical conditions?
So BMI is the gold standard that has been used in many of the outcome trials, and it's because it's very simple. You can have it in virtually any place by having your height and your weight using a formula. And most of the studies have used that. But in some patients, the BMI might not really represent what is really the status of the body fat. And sometimes it's necessary, or if it's available, it's better to use other methods that can measure the percentage of body fat versus lean mass, which is the component of the muscle versus the fat. So I think that in some patients, BMI might not be as accurate as in other patients, but BMI still is one of the best measurements that we use in clinical practice.
Thank you very much. And we have another question for this evening. Feel free.
Maybe one quick second, just to clarify that. So what BMI is a measure of weight versus height, right? I mean, essentially, it's a calculation. So when you say, oh, he's big boned, or he's thin boned, he's really not fat, or she's really not heavy, what it does, I think, is normalizes it for your body size. And so we have normal values as to what a body mass index, which is what BMI really stands for. So I just wanted to make that clarification, but what Dr. Bernal said was absolutely right.
Can I add?
Of course.
Can I? So I agree. And that's why what I mentioned before, we need, it's very compelling that we need precision medicine also to stratify the risk of the patients or everybody, not just the patients, not based on BMI, but based on the body fat distribution, but not only the body fat distribution. Now we have techniques and to go even deeper and to look at the specific fat of the specific organ. So that will tell us whether a person is a higher or lower risk, regardless of the BMI. So you may have a very thin person with the extra adipose tissue around the liver has a much higher risk of having metabolic problems than a super obese patient that everybody say, oh, that guy has for sure some problem.
Well, yeah, but also the genetics. Go ahead.
Yeah, and I mean, it's been hip lately to bang on BMI and talk about how bad it is because, it doesn't mean everything for everybody. The truth is, for the great majority of people, it is a pretty good indicator of overall weight and obesity. It's not perfect. If you're a Division I college athlete, definitely is not good. But most of us aren't D1 college athletes, and so we kind of fit into the BMI categories pretty darn well. But all these things that we're talking about, we use body composition in our clinic on top of BMIs. I know Gianluca does the same sorts of things as well. But it's not to say that like you should just ignore what your BMI is or what somebody's BMI is.
Thank you very much. And our question from the audience?
So I have read about ketogenic diet. So I would like to know more about it. Is it beneficial or is there a side effect? And what kind of population is it for? So, because it's like high-fat diet. So what's the benefit of it, and what's the population like for?
So ketogenic diets are where you cut out basically all carbohydrates. We try to get you down to below 100 grams of carbohydrate. Usually it's under 40 grams of carbohydrate a day. That's very, very low. I think most people view the ketogenic diet as eating only meats. But in fact, if you really followed a true ketogenic diet, there are many vegetables that actually are low in carbohydrate. The unfortunate thing is people don't traditionally follow it in that sense. I think part of why people lose a lot of weight on a ketogenic diet is you're losing glycogen stores, right? Because your body has to have those carbohydrates and that's glucose for fuel. So you break down glycogen stores very rapidly, and then for energy sources, and your weight drops. But it's also fairly low calorie. Usually people drop their calories. As Dr. Weiss mentioned, the minute you start looking closely at your diet, like, okay, I'm all in, I'm gonna do this ketogenic diet, and you really start looking, you cut a lot of stuff out, and weight loss comes. As a cancer prevention person, and in the cancer world, I have a very hard time recommending a high-fat, high animal consumption diet. We know that colon cancer risk is dramatically elevated with animal processed meats. So I would say overall there are much healthier diet patterns that people could follow. There are a few medical cases where I think a ketogenic diet is helpful. There's certain types of brain tumors, right, where we actually put people on a ketogenic diet and it's very beneficial. I think those are few and far between. I think there is a healthier way you can follow a lower carbohydrate diet if that's something that you're interested in. But by and large, I think there are healthier diet patterns people could do.
I agree with Tracy. Can I add something more? So I think that there is good and bad about a keto diet. So first of all, it would be effective in a very short term, because something that's very fascinating is coming up, that if you increase the ketones in your body, those ketones are used as alternative source of energy instead of glucose. And the organs like to use less expensive fuel. So ketones are much less expensive than glucose, like the heart, the brain. So they like to use the ketones rather than the glucose. However, if you do that in long term and a very, very strict keto, so you make your body more insulin resistant, because the body is basically mobilizing the fat from your body itself, and that makes you more insulin resistant. That is a bad thing for your glucose, for cholesterol, for everything. So in a long term, it's not a good thing. In a short term, it may be very beneficial.
Thank you. And this question is for Dr. De La Cruz Munoz. How long should one try non-surgical weight loss before progressing to surgery?
I think everybody's a little different. You need to feel that you've really tried everything. Most people think that surgery is the last step option, and it really doesn't have to be, but I think you need to have given weight loss a real attempt. The great majority of people will not have long-term success for a significant amount of weight loss using non-surgical approaches, but some people will. So I think you need to try it and see if you can do it in a supervised fashion. And then once you've tried and haven't been successful, then it's time to move forward and not think of it as a failure, but really a physiologic thing. And just like any other treatment option, that you would try a different medicine for your high blood pressure. If one didn't work, you try a different treatment option if this doesn't work.
Wonderful. And you know who to call as well. He's right here. And we have another question from the audience.
Hello. I'm wondering about if there are certain conditions that the doctor, endocrinologist would say you should never ever take a GLP medication. For example, someone who is in remission from cancer, or just in general. I'm not going to get the specifics about my condition, but an endocrinologist told me that. So I'm wondering about just your general advice about those issues.
In general, you correct me if I'm wrong, Chief. In general, there are two absolute contraindications for the use, three. Make that three. For the use of these GLP-1 agonists, the first is something called a certain type of thyroid cancer called medullary thyroid cancer. It's a very rare, it's not the usual thyroid cancer that you have, and there's no indication that the papillary or follicular thyroid cancer is a contraindication. But for some reason in animals, there's not any human data to indicate that it causes cancer, but if you have already established medullary thyroid cancer, something called multiple endocrine neoplasia type 1, those individuals should not be on GLP-1 agonists. If you have pancreatitis, you should not be on GLP-1 agonists. If you have type 1 diabetes, it's not indicated for the use of type 1 diabetes. Though, and of course, if you're sensitive to any of the components of these GLP-1 agonists in terms of allergies, you shouldn't take it. Did I miss anything, Ernesto?
No, there is also some data, especially in multiple trials, where there is increase in cholelithiasis, which is gallstones, and that can happen. Right? It's not a contraindication, but some people can have, some events of cholecystitis and gallstones. So,
Is previous pancreatitis a contraindication?
It depends what the cause of the pancreatitis was. If it's gallstone pancreatitis and they got rid of their gallbladder, no. If it's some sort of genetic defect that is caused, which we now know is their inherited pancreatitis and so forth, then I would say yes.
Yeah, it's still controversial because there's some recent meta-analysis, so studies that they were looking at multiple studies, and they actually found that the risk of having a pancreatitis on GLP-1 is exactly the same of any other medication. So it's still a contraindication, so I agree, of course. I don't prescribe a GLP-1 if you have or had a pancreatitis. However, it's common that the pancreas is interesting that if you measure in the blood the enzymes that the pancreas physiologically secretes to digest, because the pancreas is an organ that helps us to digest the food, you find a minor elevation in these enzymes. This seems to be a sort of adaptive mechanism that the pancreas to the effect of the GLP-1. So I think that there is still something that we don't know yet, but I totally agree that pancreatitis is still a contraindication. To answer to your question, we don't have data showing that cancer or remission should be a contraindication. Actually, I would say that if there is an excessive adipose tissue or obesity, it definitely actually is well indicated that will potentially benefit the cancer.
The only thing I can add around the cancer question and these medications is a recent trial was published. Remember, these are relatively new drugs that we're starting to look at cancer outcomes. I do think there's not been a study yet that has, to my knowledge, that's looked at recurrent disease, but in terms of primary prevention of cancer, we are seeing reductions in those who were on the GLP-1 medications. So I think more research is needed, and it's probably forthcoming and underway right now, if I had to guess.
So Tracy, that brings up the question as to whether or not the medication is what is having the effect, or is it the weight loss? Because we know the association of obesity with cancer. Have you any insight into that?
I don't think we know. I think it's still untold. I think right now the current hypothesis is the body fat tissue diminished, and that is what decreased the risk, because as you mentioned, 13 obesity-related cancers, the logical association. However, I think that there is much to be learned about what's actually happening mechanistically.
Yeah, there are some very preliminary data showing some anti-inflammatory effect of this medication. What that means, when you have a cancer, your body reacts, and there is increased inflammation. That inflammation actually may affect the cancer itself outcomes. And this medication may have some beneficial effect in that regard, even irrespectively of the weight loss. But I agree with him, we need more data.
And Dr. Gray was talking, the obesity surgery does decrease the risk of multiple cancers in the future, obesity-related cancers. So there definitely is a link with weight loss and decreasing some cancer risk. So that may be the effect that we're seeing. It's just kind of hard to tell, if that's the only effect.
So, Nestor, not to get too technical, but when you do the surgeries, you also change the hormonal milieu, which is also perhaps maybe an effect on it in addition to the weight loss.
Well, I like to say that all of these guys owe us because
exactly.
Because a lot of what's coming out now has been the pharmaceutical companies trying to copy a gastric bypass. Yep. And back in the early 2000s, we started seeing that, interestingly enough, in type 2 diabetics and obese patients, GLP-1 levels don't respond to sugar like they should, something called the incretin effect. You don't get the surge, and therefore you don't get the insulin that you should get to help you control your glucose levels in obese patients and type 2 diabetics. Well, after bariatric surgery, all of a sudden you get these surges in GLP-1, GIP, a bunch of other hormones, and ever since then, since nobody likes to get cut, pharmaceutical companies have been spending a lot of money in trying to make copies of what we do surgically with drugs. Well, now this is what we're seeing. Dr. Bernal mentioned not just GLP-1, but there are combination drugs doing 2, 3, 4 different hormones, trying to combine them to really do a medical gastric bypass. And that's how they've gotten closer and closer to the weight loss results of bariatric surgery. So in 2005, I used to tell everybody I was a plumber. I would change the piping and make it smaller, and that's how people lost weight. Now I tell everyone I'm an endocrine surgeon. Yeah. Not quite a scientist. Not that smart, but an endocrine surgeon.
No, but what about the type of bariatric surgery? So is there any difference in terms of cancer prevention?
I don't think that they've shown differences in cancer prevention in the different bariatric surgeries. We do know that the more you do to the GI tract, the more you change the hormonal milieu. So a gastric sleeve is stronger than a band, a bypass is stronger than a sleeve, and a duodenal switch is stronger than a bypass. So we've shown that it increases the resolution of comorbid conditions due to obesity, but I don't think anyone has broken that down over the long-term period to show increased cancer resolution with different surgeries.
Thank you very much. And we have a question from our audience member.
Hi, my name is Nicole. I'm a fourth-year student pharmacist from the University of Florida College of Pharmacy. So drugs are obviously something that I'm very interested in. However, I wanted to focus a little bit on genetics. So what happens to patients who are contraindicated in these GLP-1 drugs, but then we know social determinants are a huge thing. Patients can't always afford the drugs, or sometimes they can't afford bariatric surgery. So what can we do for those patients who these aren't an option for them, and yet genetics are playing a huge part in their weight loss journey?
So, just because I'm the fastest on the draw here, I'll start. So there's two different things. There's social determinants of health, and then there's the genetics of health. I think we know little about both of them. In terms of the social determinants of health, we do know that obesity and weight management is extremely problematic and challenging in individuals that don't have access to healthy foods. People that can't afford, it's not cheap to eat healthy and to have fresh vegetables available to them if they live in a food desert, as it's known. Certain zip codes, certain cultures don't allow for the dieting. And so that is something that will not be answered by even the medications. And then in terms of the genetics, we still have so much more to learn about that. I think the cost of these medicines you bring up, it's extremely expensive. If you don't have insurance coverage, it's probably about $3,000 a month. Maybe, and if you have insurance, your copay can be as little as $25, and it can be as much as $600 a month. So even for people with insurance, this is an expensive proposition, especially as Gianluca says, you're going to have to be on this forever. So, almost. So, indeed, it's expensive. We need to work with the pharmaceutical companies. There's no genetics there. There we need to work. Why is it so expensive? If this is a panacea for the treatment of so many things that are affecting their heart, their kidneys, wouldn't it be better to have the insurance companies pay for the medication rather than to pay for a heart or kidney transplant? So these are other societal public policy issues that we need to work on during this very disruptive period in medicine.
I like to add about the genetics, especially, being a pharmacy student, you're probably familiar with pharmacogenetics and how people respond differently to the same medication. And to say about the GLP-1s, there are variants in the GLP-1 receptor that can alter the response. And in fact, we see sometimes in clinical practice that some patients respond more than others to these medications. So we still need to learn more about what is the implication of these genetic variants in the GLP-1 receptor.
So I'm going to add one more thing about the social determinants of health. So I think we can't forget, it's important for all these medications, it's important to have insurance coverage, but things like mobile food pharmacies and having access to food, and we can't forget along the way that there are other resources that are needed. And so I think having people like you and others that advocate for things like having food pantries, like having access to walkable spaces, like these are all important things that are not going to go away and that still need to be addressed.
Yeah, this is a bigger issue than any of us can address, because even in surgery, we're seeing about 1.5% of potential patients a year. Yeah. Even with medicine, I've been hearing anywhere from 3% to like 8% have tried GLP-1s. We can't, as a society, pay for everyone, even if they're cheap. You can't pay for everyone who's obese to have these drugs. But we need to work on fixing our food supply, fixing our parks, fixing our society, fixing things so that we don't have as much obesity in the society, and taking us back a couple of decades before we got into this trouble.
I think your point is well taken. I mean, we cannot afford to treat all the epidemic of obesity, but the next challenge is to identify who are the patients that could benefit the most of the medication. And that's where maybe some of the studies that are designed now is to identify a subgroup of patients that will get the most benefit.
So there was a period of time when these drugs were really hard to come by. You couldn't find them for love or money. And now they're a little bit more plentiful. So what would you say about a 38-year-old woman who's going to marry off her son and has to be in a certain size 4 wedding dress and just needs to lose 10 pounds? Should that person not be deserving of the GLP-1 agonist, or in a world where it wasn't limited in terms of access? How would my co-panelists feel about that?
Yeah, so excellent question. So because that is it's happening every day. So in my clinic, actually, I'm in favor of using this medication or other options. Even the goal it's more social, cosmetic, or not necessarily a game changer in a disease. We may have, for that specific person, we may have another option that may help to lose just for the wedding. So we may use phentermine or other medication that can help it to lose.
What about a girdle?
But in general, so I think that losing weight and losing visceral fat, particularly so the fat around, it's beneficial regardless. So I think that all the news, the commercial, and all the non-scientific media blaming people trying to get the GLP-1 only for weight loss purpose, I think that they were not completely correct, because losing weight is beneficial in any way.
But they will regain it back a few weeks after the wedding.
So,
Depends
One
on
that
the-
wears the wedding dress the second time.
well, that's what I was going to say is let's have a conversation about why the size 4. And let's think about anybody can do something for 3 days. People can do something even probably for 3 weeks. But it's about getting to the point where this is a long-term lifestyle behavior change. And I think, I mean, I respect everyone's opinion, but I do think a quick 10-pound drop, there's more going on there than, you know, let's think about this, and there's maybe some other things we can do.
Yeah, I always tell my patients, you should be able to lose weight. It's the maintenance of weight that's a physiologic difficulty, but the weight loss itself is willpower.
Yep.
And so you should be able to lose some weight if just by gutting it out.
Yep.
But at some point you can't suffer anymore.
I agree, of course, but if you have the same person and you find out when you meet the person that has a family history for heart disease, some comes from some ethnic groups, and that comes to genetic, and so some potential risk, even is at the time that he's seeing you is healthy and is asking to lose weight only for apparently not unnecessary reasons. So I think that knowing the beneficial effect of these medications and weight loss in general, and mostly mediated by these medications, so you may actually accommodate the request looking at doing a preventive action.
I'm looking at more severe disease. When they come to me for 10-pound weight loss for a wedding, I like look at them like, are you crazy?
Has that ever happened?
No, they don't get to me. They don't get to me.
Well, but we have to be careful because in today's environment, how often does a doctor have the ability to sit with their patient for an hour and try and understand what is it that's motivating them to eat? I mean, I wish I had that time. My boss would fire me. I wouldn't be able to see enough patients in the course of a year if I were to spend an hour with every patient trying to understand the reason why they're eating is because their mother-in-law doesn't treat them nicely. I mean, but till you get to that point, it takes time, and you have to talk to people. There's always something else going on, and and there's so many people with eating disorders out there that need to be evaluated and looked at in that regard as well.
What a great question. And we have another one from an audience member as well. Sir?
Well, I want to thank you because you've actually just been addressing what really was the origin of my question, which is a lot of the lifestyle and the prevention. So the surgeries that you do, they're going to cause permanent nutrient absorption problems. I've been reading that the GLP drugs also have severe nutrient deficiencies. But the real issue is big ag, big food, make billions selling us stuff we shouldn't eat. Where does it come down to if we would just eat food that's real food, that's not processed? We call it junk food. That's a misnomer. It's not junk food, it's just junk. So how much of this comes down to what the gentleman was saying a minute ago about addressing the real food issues? They say that eating healthy is really expensive, but it's far cheaper than all the trillions of dollars that we have to spend dealing with the subsequent issues. And I know you're not going to change our political system and how we affect people, but I remember when Michelle Obama told us to eat more vegetables, she was crucified. Mm-hmm. So where does it come down to, I'm a bleeding heart liberal, so I don't believe America's gone soft, but I think we've gone soft in being able to tell people, look, don't eat junk.
My wife is Greek, and so when we go to Greece and go eat, the food even looks different over there than it does here. Not the way it's prepared, but a piece of chicken breast looks different than a chicken breast here. The vegetables look different than they look over here. So you're right, our food supply has been tainted, and the problem is it's the easy, cheap food filling the center of the grocery store. That people have access to. And unless we make it more difficult and more expensive to eat that type of food, then that's where people are going to go.
So people don't like the idea of food tax on foods that are unhealthy. However, tobacco tax was quite successful at reducing smoking rates. I think that the food system has to change. And to your point about Greece, they have very different food regulations in Europe. Things that are allowed here are not allowed there. And why is that? I mean, it's a whole deep dive beyond this conversation probably, but other than to educate yourself and to be aware and to wherever you can make change, to make change because it needs to happen.
Yeah, but I mean, it's a kind of stereotype that European food or other countries, it's healthier because obesity is actually the prevalence is increasing also in Europe and other countries. So it's not just a problem in the United States. And I think that, of course, you're right, but I think that it's a kind of too simplistic to blame about food, because again, it's much more. Again, you may have a person who is eating healthy, but unfortunately has bad genes or bad family history or poor body fat distribution or unfavorable body fat distribution. Even the person is eating as healthy as possible, is going to Greece or to Italy every month, he may have a higher cardiovascular risk than a person that is grossly obese, eating junk food, but with good genes protecting them. So I think that there is much more complex than that.
Thank you. And while we are coming to a close of our program, we have questions and we want to make sure they're answered. Go ahead.
I just wanted to ask a question for one of our guests. If there is an impact using GLP drugs for women of childbearing age, is there or isn't there?
That's a good question. PCOS.
There are no data, so there was faster than you this time. So there are no data. Definitely, you cannot. If you are pregnant, you have to stop using GLP-1. So definitely, there are no data, and very likely there will be no data. So I don't foresee that GLP-1 could be used during pregnancy.
But in general, absolutely, I agree with that. In general, women of childbearing age need to be mindful of two things. One, if they're on birth control pills and they don't want to be pregnant and they start GLP-1 agonists, the transit time of these oral contraceptives will be altered, and women can get pregnant. I was having this discussion with one of the psychologists in the audience. Women can get pregnant on oral contraceptives with GLP-1 agonists. As a matter of fact, our anesthesiologists tell you to stop the GLP-1 agonists prior to going to any procedure or surgery. So that's one thing with regard to women of reproductive age. The other is a very common metabolic syndrome is called polycystic ovary syndrome. Some of you may be aware of it with women that are high levels of testosterone with polycystic ovaries and failure to gain weight and diabetes. Those individuals actually benefit of childbearing age that are able to lose weight, and then there's data to show that they can conceive. So those are the two nuances, but during pregnancy, for sure not.
And do we have one more question from the audience? Yes, we do. Go ahead, sir.
Hey, doctors. Good evening, everyone. Thank you very much for taking time to be here. Extremely informative. So my question has to do really with the last word in what this is all about, which is, wellness and time management. So we know that you have to eat well, but you have to exercise as well. It's coupled together. So here's my issue. I drive home from the office at 7 p.m., and I see people walking their dog, and they're cycling, and they're walking, and I'm thinking to myself, why am I leaving the office at 7 p.m.? I eat well. I was at my physical this past week, and my physician said, well, Andrew, you're a little heavier than you should be. So now comes the time management part. I don't think I'm alone in this, conundrum of mine. So when is the right time to exercise? Should it be in the morning? Should I leave the office and go downstairs and work in my gym, work out in my gym during the course of the day? Should I do it at the end of the day? And how long should I do it? 40 minutes, a half hour. So these are things that for someone who's still working, it's really important for me because I used to work out regularly every day. And I weighed 175 pounds. It was just right. Today I weighed at 194. That's not good. So, from this expert panel that I'm looking at, what would you tell me, or what would you advise me to do, please?
So first
Thank
of all,
you.
I would say thank you for bringing up exercise, because we haven't talked about exercise at all, and that is definitely a huge component to weight management and health and wellness. I would say any time of day you'll do it. What works for you? Because I don't think we have scientific evidence outside of elite athletes, where we do have evidence for certain times of a day where they need to shave half of a millisecond off. I mean, we're talking about extreme. Then we can definitely see shifts in when you exercise and your performance. But for the general public, I think that whenever you will do it and it works for your schedule is when you should do it. I think it's important to have strength and aerobic. I think that we're learning so much now about the importance of we talked about body composition and muscle mass. So strength training is incredibly important. And as we age, balance, don't forget balance training. So I know it sounds like a lot, but whenever time of day you'll do it, and try to have variety in what you do.
Do what we say, not what we do.
Wait, I exercise today.
Yeah, so about the exercise, so actually, so definitely excellent. I'm a former swimmer at competitive levels, so I cannot say that exercise it's essential for everything. However, if you're looking to lose weight through exercise, you may be disappointed. So it depends, of course, every person is different, but for weight loss purpose, not for to improve your cardiovascular performance, your health, you may actually need a different type of exercise. You may need interval training, anaerobic exercise. So the traditional walking on the treadmill or walking the dog may not help you to lose the weight. Will definitely improve your glucose, your cholesterol, your blood pressure, but not lose the weight. So it's very complex. Yes, that's what I wanted to add.
I think one thing you can also do, and this sounds so, but people come to me and say, I want to improve, I want to lose weight, what do I do? The things that I tell people to do: 1, don't eat past 8 o'clock. 2, after you finish your meal for the evening, walk 20 minutes, or at least be up and moving. Do not sit at the table after you finish your last meal of the evening. Get up and walk around. I don't care if you do laundry, I don't care if you do dishes, just don't sit. And then the third thing is try to incorporate. It's always easier to add than subtract, and try adding more plant-based foods to your diet. I try to get 30 a week. I try to get 30 different plants a week in my diet. Sounds like a lot, but when you start looking at it and start trying, it's really not. Cilantro counts, couscous counts, right? Whole grains count. I mean, seriously, it's an easy thing to think about. How can I add more plants to my diet?
And thank you to our panelists. I feel like we could have this conversation all evening long, but unfortunately we are out of time. Thank you again. Seriously, I think this conversation has been quite insightful. We've been able to answer a lot of the questions from our guests as well. As always, we wish your family good health. Have a wonderful night. Thank you.
That was great.